Good morning. Today we'll be having a seminar on basic aspects of oncology. Uh, Dr. Sanjay Devakshi, who is a consultant surgeon and a very good teacher, uh, now attached to AMRI Hospital, Dhakuria. He will take us through the scenario of this seminar. And the first presenter will be Dr. Anuradha Maji, who will speak on clinical significance of oncogenes, tumor suppressor genes, and tumor markers. So, Anuradha, please share your screen and start.
Good morning, sir. Good morning, everyone. Today I'm going to present on the principles of oncology regarding tumor suppressor genes, oncogenes, and the clinical significance of the tumor markers. Tumor cells usually have these properties of
Anuradha, your sound is not clear. Just make it a little louder.
Sir, is it clear now?
Yes, yes.
Okay, sir. Good morning, sir. Good morning, everyone. Today I'm going to present the principles of oncology regarding the tumor suppressor genes, the oncogenes, and the clinical significance of the tumor markers. The tumor cells have certain properties like self-sufficiency of the growth signals, insensitivity to the anti-growth signals, evasion of apoptosis, unrestricted replicative potential, sustained angiogenesis, tissue invasion and metastasis, and genetic instability. All these are possible with the certain molecular basis which occurs, which lead to the formation of a normal cell to a malignant neoplasm. This slide shows the flow chart where acquired environmental DNA damaging agents cause DNA damage, and following which, if there is failure of DNA repair, that leads to mutation in the genome of the somatic cell. And it can be a proto-oncogene leading to formation of an oncogene. Following that, it can also be alteration in the regulation of apoptosis, or it can be inactivation of the tumor suppressor genes. So these leads to altered gene products and or altered regulatory pathways that leads to clonal expansion and additional mutations which lead to heterogeneity and which paves the way for formation of malignant neoplasm. The cancer critical genes are the oncogenes and the tumor suppressor genes. This slide basically differentiates between the tumor suppressor genes and the proto-oncogenes. The tumor suppressor genes are primarily protective genes that help to control the cell growth, and mutations in the tumor suppressor genes that will lead to inhibition of the progression of the cell cycle, causing in the development of the tumors. Tumor suppressor gene, as usually, they cause cell division, and their inactivation will lead to loss of function, which will lead to cancer. Usually, deletions and point mutations are the main cause of the mutations, and they can occur in the somatic or in the germline. So they are seen in both somatic and germline cells. And while the proto-oncogenes, they are the normal genes which have various functions in the cells, and after mutation they become oncogenes, and they contribute through various pathways to cancer. So mutations alter the gene products which are produced, and they lead to increased expression of the cancer cells, which I'll be discussing later. And usually it causes activation of the cell division, and so this is gain of function mutation which causes cancer. And here usually point mutations, gene amplifications, and chromosomal translocations are seen. And this proto-oncogene to oncogene transformation is mostly seen in the somatic tissue. Sir, these are some of the examples of oncogenes and the tumor suppressor genes. For example, oncogenes like EGFR, HER2/neu, or RET proto-oncogenes, they have specific functions like they code for epidermal growth factor receptor or a growth factor receptor. But when there is a mutation, they lead to various human cancers like glioblastoma, breast, head and neck cancer, colon cancer. Other examples of the oncogenes are KRAS, NRAS, MYC, NMYC, BCR-ABL, BCL2. Examples of tumor suppressor genes are APC, which is an NF1, NF2, RB1, P53, which is the guardian of the genome, and gene mutations like BRCA1, BRCA2, VHL, MSH2, MHL1, PMS1. All these can also act as genetic markers of tumor markers. For example, P53, it has various functions which lead to inhibition of malignant neoplasm formation. For example, P53 leads to activation of MDM2, and it actually causes growth arrest of the cells by induction of P21 and inactivation of RB gene, and it leads to activation of apoptosis in DNA damaged cells. It also helps in repair of DNA damage. And this slide shows how P53 is actually a guardian of the genome. Now, P53 was a tumor suppressor gene which functions in this manner. How a proto-oncogene can become an oncogene, this has been shown in this slide. Here, a proto-oncogene which produces a normal protein, either there can be a mutation or deletion which will lead to altered structure or function of the encoded protein, or there will be gene duplication which will lead to increased synthesis of the encoded protein, or which can be a growth factor which will be increased and will lead to increased proliferation of cells, or it can be a DNA regulatory sequence translocated from a distant site which will alter the expression of the gene, and that will lead to increased synthesis of the encoded protein. Or there can be synthesis of a protein containing portion encoded by different genes. So fusion protein is formed, which will not have a similar regulation like a normal protein. And so all these will lead to formation of a proto-oncogene to a oncogene. In tumor suppressor genes, usually they have a recessive character, autosomal recessive character, in which there is a two-hit hypothesis, where first hit is due to a germline mutation which has been there from before, and then the second hit occurs during the lifespan, where there is a deletion, there can be a deletion of the normal allele that will lead to both the loss of both the alleles, and that will followed by that will lead to expression of the mutant allele and cause aberrant protein formation or lead to loss of function of the tumor suppressor gene. Now I'll be coming to the tumor markers. The tumor's markers are the substance which are produced by a benign or malignant tumor or by the host in presence of the tumor, and they can differentiate tumor from normal tissue. And we can measure or assay the tumor markers, since they can be secreted in the serum or in any body fluid, or they can be present on the surface of the cells or in the nucleus. They are therefore indicators which are cellular, biochemical, molecular, and genetic alterations which help in the recognition of neoplasia. Thus, there are various significance of tumor markers. They can be used as screening in the general population. They can be used for staging and subtyping and classification of the tumors. Tumor markers can correlate with the tumor size or the tumor burden. They can be used as a prognostic indicator of disease progression, and they can guide the choice of therapy. They can monitor how much tumor burden is remaining or how much is the response to therapy, and they can also evaluate the success and the recurrence. If the tumor markers are increased, that might show an early recurrence more than the clinical or imaging. Tumor markers can be classified according to various types. Here I have classified it according to protein markers, genetic mutation markers, and epigenetic markers. Where protein markers are widely used, protein markers, they are the first type of tumor markers that have been identified, and so they are also called classical tumor markers. And here all the examples what I have shown are all secreted in the serum. So serum CEA, carcinoembryonic antigen, alpha fetoprotein, carbohydrate antigen 125, carbohydrate antigen 19-9, prostate specific antigen and beta HCG are some of the protein tumor markers. I shall be talking about the very important tumor markers here. Carcinoembryonic antigen is a tumor marker which detects cancer of the colon and rectum. It is a oncofetal protein which is produced during the fetal life and normally present during the fetal life, and gradually it becomes very low concentration in the healthy adults. It is secreted in the circulation and also found in the mucous secretions of the stomach, small intestine, biliary tree. Normal level is less than 25 and elevated if it is more than 50 nanogram per ml. But serum CA can be borderline increased in inflammatory bowel disease, pancreatitis, cirrhosis, COPD, and heavy smoking. And serum CA is most sensitive for hepatic or retroperitoneal metastasis rather than local or pulmonary or peritoneal involvement of colorectal carcinomas. And it has more of prognostic value and can detect recurrence rather than screening, since it is non-specific and present in small amounts in early stage of the disease. AFP, alpha fetoprotein, is used in hepatocellular carcinoma and non-seminomatous testicular cancers. It is also oncofetal protein. It is synthesized normally by hepatocytes and endodermally derived gastrointestinal tissues. The normal level is less than 25 nanogram per ml. It is increased to more than 400 nanogram per ml in large tumors. It is also increased non-specifically in inflammatory bowel disease, hepatitis, cirrhosis, but it is a good indicator for recurrence of disease. For example, previously if AFP was increased, if there is a recurrence, there is an early increase in AFP levels in blood. Carbohydrate antigen 19-9 is used mainly for pancreatic cancer. It is a mucin type of glycoprotein which is expressed on the surface of the pancreatic cancer cells. And it is detected by immunoassay, immunohistochemistry. Normally, it is present in the biliary tree. So any disease of the biliary tract can increase the CA19-9 levels. And some liver diseases associated can also increase the CA19-9 levels, and those levels can go as high as 400 units per ml, where the normal value is 0 to 37 units per ml. So it is not a very good diagnostic marker, but it is useful for monitoring of therapy. In pancreatic cancers, usually in significantly large cancers, it can be more than 1000 units per ml. It is also seen to be increased in carcinoma stomach, colon, liver, lung, and biliary tree. Prostate specific antigen is a tissue specific marker which is increased in diseases of the prostate. And it is a serine protease marker. It is formed in the prostatic epithelium and it is secreted in the prostatic ducts. And it can be detected by immunoassay. It is increased in prostatitis, benign prostatic hyperplasia, prostatic biopsy. Even digital rectal examinations can increase the values of PSA transiently. The upper limit of prostate-specific antigen actually increases with age, which is 2.5 nanogram per ml for 40 to 49 years, 3.5 for 50 to 59 years, 4.5 for 60 to 69 years, and more than 65 is the upper limit for more than 70 years males. Prostate-specific antigen is a screening tool for prostate cancer. it can enable early diagnosis. Prostate specific antigen density is a ratio of prostate specific antigen to the prostatic volume measured by transvaginal ultrasound or MRI. And higher prostate specific antigen density is highly suggestive of malignancy. The prostate specific antigen levels normalize almost within 2 to 3 weeks of operation, but with radiotherapy, it takes almost 3 to 5 months to normalize. CA125 is a carbohydrate epitope on a glycoprotein antigen. It is present in fetus and in the derivatives of the coelomic epithelium. So, peritoneal, pleural, pericardial, and amnion will have CA125. It is detected by immunohistochemistry. It is normally also present in the epithelium of the fallopian tubes, endometrium, endocervix, and normal fetal or adult ovaries do not express CA125. Normal adult ovaries do not express CA125. So when there is increased CA125, it is suggestive of ovarian carcinoma. It can also be increased in CA cervix, endometrium, fallopian tubes. It can also be increased in carcinoma of pancreas, colon, lung, liver. And the normal value is up to 35 units per ml. It can also increase in benign diseases like endometriosis and adenomyosis, fibroid uterus, pelvic inflammatory disease, cirrhosis. So it is very non-specific and is not a useful screening tool for ovarian cancer. But it has a good prognostic marker. There is a good response to therapy. There is decrease in CA125 level, and with recurrence, CA125 level increases, which is earlier than any clinical or imaging investigation. And the CA125 level in peritoneal fluid is more sensitive than in serum levels, and the upper limit in peritoneal fluid for upper limit of normal value is 200 units per ml. Here I have presented the AFP significance of alpha fetoprotein and beta HCG in testicular germ cell tumors. Testicular tumors with increased AFP or HCG is highly suggestive of testicular cancer, and increased markers with age of less than 40 years without any signs of testicular tumor can indicate extratesticular germ cell cancer. Usually more than 90% of choriocarcinomas will have increased level of beta HCG. 90 to 95% of yolk sac tumors will have increased serum alpha fetoprotein levels. And alpha fetoprotein levels of more than 500 nanogram per ml or beta HCG value of more than 1000 nanogram per ml is predictive of poor prognosis. And in non-seminomatous germ cell tumors, the levels of AFP and beta HCG correlate with the response of therapy. The rate in marker decline that can be used in the early assessment if there will be and predict whether there will be a poor response to chemotherapy. The half-life, so as we see the response to therapy, we see the half-lives of beta HCG and AFP. If the half-life of beta HCG is more than 3.5 days following starting of treatment, and AFP half-life is more than 7 days, then it suggests that more aggressive treatment is required. These were the protein markers. Now I'll be talking about the DNA-based markers of the genetic mutation markers. These are the specific mutations which are present in the oncogenes, tumor suppressor genes or mismatch repair genes, which serve as tumor markers. These are examples like APC gene of the familial FAP germline mutation in the proto-oncogene of MEN2, somatic mutations in P53, and chromosomal mutation in BCR-ABL oncogene 920 created by 922 translocation. Epigenetic changes are novel type of tumor markers which are still in the process of study. They actually detect the aberrations of the DNA methylations, and those are detected by DNA assays. The DNA methylations are are easier to detect rather than point mutations, and they are more sensitive. And DNA methylations are detected rather than RNA or protein methylations or alterations, since they are more stable in diverse body fluids. And they have been epigenetic changes have been studied in CA breast, esophagus, carcinoma, stomach, colorectal carcinoma, and prostate carcinoma. This slide actually shows how, for example, in a CA breast, how various tumor markers can help in the diagnosis of carcinoma breast, in which the known tumor markers are the hormone receptor markers, which are ERPR, and also oncoprotein markers like HER2/neu. When ERPR positivity actually is associated with luminal A, and it has a good prognosis, and HER2/neu positivity, Herceptin sensitivity, Herceptin can be used, so it also has a good prognosis, although luminal A has a much better prognosis. Genetic mutation markers are BRCA1 and BRCA2, and novel serum markers are CA15-3 and CA27-29, where CA27-29 is more sensitive than CA15-3, and some potential protein markers which are highly expressed are MUC1 and mamaglobin, and other markers can be adhesion molecule markers, which can be E-selectin, ICAM1, VCAM1, cytokeratosis. So all these help in the molecular typing of the carcinoma breast. Thank you, sir.
Professor Shah, can I come in?
Yeah.
All rather wonderful presentation.
Thank you, sir.
Few points I needed to make. When you talk about an oncogene, basic pathways you say are cell proliferation and lack of apoptosis. There's one other important pathway, the fact of differentiation. It stops differentiation, which is why you have de-differentiated cancer cells, and which is why you have the fetal oncogenes being assessed in the blood. I mean, that works as a tumor marker. So that is number one. Number two is tumor markers. You yourself, as you presented, it's not a very good tool for screening. But can you tell me something that is regularly one of the tumor markers that is regularly being used for screening? Can you tell me?
ERPR HER2/neu for carcinoma breast.
Yes, but that is after diagnosis. I'll come to that also. But for screening, you don't screen for ERPR and HER2/neu, isn't it?
Yes. Prostate-specific antigens.
Very good, excellent. So that is something that above the age of 60, most developed countries would actually advise any person above the age of 60 to have a prostate-specific antigen done. Okay. Then the other thing that I would also make an issue about is when you're presenting the breast, just before the thank you slide, it's more for the diagnosis, not rather than the diagnosis. It's more for giving a roadmap for the treatment, isn't it? It is very rare that you use a serum marker of the CA25.7 and things as a diagnostic tool, because as you yourself said, there are a lot of false positives that can occur, isn't it?
Yes, sir.
Hello?
Yes, sir.
Yeah, we understand that. The other final thing, Anuradha, you had an extensive presentation, but one of the principles is don't make a very busy slide. It's very difficult to read. So the principle is minimum font 20 and maximum number of lines, 7 lines per slide. That's just the observation. Your last slides your presentation was fabulous. Thank you.
Thank you, sir.
So basically, Anuradha, you have mentioned about these two group of genes. One is tumor suppressor gene and the proto-oncogene, which goes to oncogene. And this oncogene needs amplification for expression of malignant change. Okay, so the other two basic. The tumor suppressor genes are mutated to prevent the inhibition of cancer, and oncogenes are amplified for development of cancer. Okay, so
Professor Shah, it's also an important point that oncogenes are principally autosomal dominant, whereas tumor suppressor genes are principally, in principle, recessive. So that's something else that you need to keep in mind.
And another thing, Anuradha, when we have some cancer which is coming as a mutation of these oncogenes, they are the most of the cancer which are hereditary cancers. And this hereditary cancer has got some characteristics, like it occurs in younger age, it's more commonly bilateral, the prognosis is poorer. Okay. So, okay, we pass on to, thank you, Anuradha, for nice presentation. We pass on the next topic. Dr. Shottam from Barashat Hospital will present, and he will talk on these newer therapies of targeted therapies and gene therapies and hormonal therapies for cancer. Dr. Shottam, please share your screen and start.
Hello, am I audible?
Yes, a little louder, please.
Hello, good morning, everyone.
Yeah.
Today I'm here with you to share my presentation on targeted hormonal and gene therapy in cancer. So my first slide will be on targeted therapy. Targeted therapy is defined as...
Please, Shottam, share your screen.
Okay, sir.
Yeah.
Dr. Satyam, should I share your presentation from this end?
We'll change it. Shottam, you can start. Dr. Milind will operate your presentation.
Okay, sir. So, good morning, everyone. Today my presentation is on targeted therapy, hormonal therapy, and gene therapy in cancer. So, starting with targeted therapy, this is defined as a type of cancer therapy which uses drugs or other mechanism to precisely identify and attack specific cancer cell. A targeted therapy can be used by itself or in combination with other treatment modalities such as chemotherapy, radiotherapy, or even surgery. Targeted therapy includes various groups like cytotoxic drugs, hormone therapy, molecular growth targets, immunomodulators, all these which are specifically designed to interact with the specific molecular targets. This targeted therapy is still an upcoming area, and many of these still are under trial and offer a modest prolongation of survival, often with a minimum toxicity but at a considerable financial cost. This targeted therapy usually target only specific subsets of tumor. We have few examples like tyrosine kinase inhibitor, where modafinil is only effective in melanoma patients having BRAF V600E mutation. Second example, we have cetuximab, which is effective only in colorectal cancer having wild type of RAS mutation. Third example, we have imatinib, which is effective in patients with GIST tumor having mutation of exon 11 of the KIT gene. Comparing it from a patient with mutation in exon 9, he will respond to imatinib but will require a higher dose, while a patient without KIT mutation is less likely to respond to imatinib. Now coming to immunotherapy. The principle of immunotherapy is enhancement of host immune response against a malignant cell. Apart from cancer, it can also be used in other conditions like bone marrow suppression, systemic diseases, and treatment of metabolic diseases, etc. Disadvantages of immunotherapy include cost and availability. Immunotherapy can be active, passive, restorative, or adaptive. Common immunotherapy agents include monoclonal antibodies, immunomodulator drugs, bone marrow transplant, prostaglandins, interferons, and interleukins. We have certain examples of tumors where immunotherapy has been successfully used. Examples include melanoma, bladder cancer, colorectal cancer, and renal cell cancers. Coming to the gene therapy. In gene therapy, the main target is alteration of specific genes of interest. In gene therapy, instead of giving a ready-made drug to treat or control a symptom, the target is alteration of genetic makeup of the patient cell. Now, this picture is a schematic representation in which a cancer cell, some gene therapy or armed oncolytic virus is being transferred. It works by 4 mechanisms mainly. Broadly, it works by 4 mechanisms including enzyme, antibody, T-cell engagers, or cytokines, which acts on the tumor microenvironment by various methods like cancer stroma depletion, immune cell activation, and tumor vasculature degradation. The single most important critical therapy in gene therapy is the selection of an appropriate vector for the delivery of desired gene into the target cell. We have certain characteristics of an ideal vector. It includes, it should be administered non-invasively. It should transduce all the cancer cells and no normal cell. Apart from cancer therapy, gene therapy is also used in the treatment of metabolic diseases. The vectors may be viral or non-viral. The viral vectors include retroviruses, which is most commonly used, adenovirus, herpes virus, vaccinia virus. Non-viral vectors include liposomal mediated DNA transfer and DNA protein conjugates. We have 2 methods of gene therapy, including in vivo and ex vivo. In vivo, in the case where viral vector is directly injected into the human body, while in case of ex vivo, we first extract some of the patient cell, which is used for the autologous culture. It is cultured artificially in the lab, and it is re-injected back into the patient cell for therapy. And now there are methods in gene therapy include germ cell therapy and somatic cell therapy. Germ cell, as we know, in germ cell therapy, insertion of gene of interest is done into the fertilized egg. The gene gets dispersed throughout the egg tissue and also ends up in the fetal germ cell. Therefore, it is inherited into the future generations. In the somatic cell therapy, we insert the desired gene into the somatic cell. Therefore, the genetic change remains restricted to the injected cell and not passed into the germ line. Coming to the goals of gene therapy. The goals of gene therapy is to compensate for a defective gene, enhancement of immune response, killing of tumor cell, and protection of vulnerable cell population against malignancy. Lastly, going to hormonal therapy. In hormonal therapy, hormone or hormone-like agents are administered to inhibit tumor growth by blocking or antagonizing the hormone itself or the hormone receptors. It is commonly used for breast and prostate cancer where the tissue growth is under the hormone control. We have certain examples where drugs are used like aromatase inhibitors, which block the peripheral conversion of endogenous androgens to estrogen. Apart from treatment, the hormone receptor status can be used to assess and predict the response to therapy, like ER/PR status in CA breast. Now going to the last slide, this is a table I have taken from Bailey where there are different types of targeted therapy, including the mechanisms and examples. So the mechanism includes the mechanism one is by resisting the signals that inhibit growth. It acts by the cyclin-dependent CDK kinase inhibitors. Examples include palbociclib, dinaciclib. Second mechanism we have, examples include EGFR inhibitors like trastuzumab, which act by sustaining the proliferative signaling. Third mechanism include avoidance of immune destruction. We have immune activators. Examples include pembrolizumab, ipilimumab. Another mechanism is telomerase inhibitors, which obtain the replicative immortality. Example is amelstat. Another examples include IGF-1 inhibitors like lincitinib, whose mechanism is acquiring the ability to disseminate an implant. Similarly, we have other group of drugs like aspirin, metformin, which also aid apart from the normal mechanism, aid in the cancer therapy. Thank you.
Few questions, Professor Shah, can I ask?
Yes.
Sotom, a point that you made was very important. All throughout these years during cancer treatment, we have always concentrated on the cancer cells. What we don't realize really is that the cancer stroma is equally important, and because it's important, people realize that the cancer cannot exist without the stroma. So that's a very important thing. It needs glucose for growth, and it needs a proper framework for growth. So that is the most important thing that we've come to realize. You've also talked about imatinib working at when the tyrosine kinase inhibitor is at zone 11. You're quite right. When you have a mutation at 0.9, which is actually you see, this is a sort of tyrosine kinase is a transmembrane protein. 11 exists within the cell membrane. 9 exists outside the cell membrane. And when you have a problem in 9, you either use a double dose imatinib. Now, the problem of using a double dose imatinib is that it is basically a vascular endothelial growth factor inhibitor, and as a result of which, most people would actually come in with huge amount of deep venous thrombosis. I've had a number of people who come back with deep venous thrombosis if you increase the dose to, from 200 to 400, 400 to 800, then you start having a problem. And as a result of which, there you might be using sunitinib as an alternative. The other thing is, you're quite right, when you have a CD kit, CD117 not responsive, the usual, that is also another transmembrane protein. It's called the platelet growth factor derived PGDFRA factor, and sometimes sunitinib actually works better on that. The other thing is, you've talked about hormonal therapy. One of the most important hormonal therapy, you've talked of the breast and the prostate. I would have expected you to talk about the thyroid also. Don't you think, Dr. Shah?
Yes. Yeah. Because thyroid is also a hormonal dependent tumor.
Very.
And Shottam, I think you should have touched a little about non-specific immunotherapy, because there are some drugs. Now we have more targeted immunotherapy, but there are some drugs which can cause non-specific immune stimulation, and these are used in colorectal cancer also. These are levamisole.
Absolutely.
Okay, sir.
Okay, so these are not, and then again the BCG vaccination. The vaccine used in bladder cancer is not a very specific drug. It's a non-specific immune stimulant.
Absolutely right.
Okay.
Okay. Now we pass on to the last topic is the main modality of treatment of cancer is by chemotherapy and radiotherapy. So Dr. Milind Alokji is a second-year resident at MR Bangalore Hospital. He'll speak on the basic principles of chemotherapy and radiotherapy. Dr. Milind.
Good morning, respected teachers and my fellow colleagues. I'm Dr. Milind Alokji, and the topic that I'll be taking today is principles of chemotherapy and radiotherapy. Now, chemotherapy, if we go by what Bailey and Love says, then in one line it says that selective toxicity is the fundamental principle underlying the use of chemotherapy in clinical practice. Now, chemotherapy destroys cells by first order kinetics, which means that with the administration of a drug, a constant percentage of cells is killed and not a constant number of cells. So each time that we give the same amount of drug, a percentage of the cells that are present will always get killed, but theoretically the total number of cells will the total number of cells will never be killed. So it is rarely sufficient to cure cancer on its own. It is a primary, although it is a primary modality of therapy in patients with documented distant metastatic disease, and where the goal is to decrease the tumor burden and thus prolonging survival. So it has a very important palliative role rather than a curative intervention. But with chemotherapy, one very important thing is that treatment should always be done in a way that it should not produce unacceptable symptoms. Now, chemotherapy can be broadly put under three headings: primary chemotherapy, adjuvant, and neoadjuvant. Primary chemotherapy is given as the sole anti-cancer treatment for some very highly sensitive tumors, such as the R-CHOP regimen in non-Hodgkin's lymphoma. Adjuvant chemotherapy is given after surgery to mop up microscopic residual diseases. Now, this is given in tumors which have a high risk for distant recurrence, but they have no current evidence of a distant recurrence. For example, adriamycin and cyclophosphamide in CFS. And neoadjuvant chemotherapy is given before surgery to shrink the size and increase the chance of successful resection, such as in the case of adriamycin and osteosarcoma. Now, when we talk about chemotherapeutic agents, they can be broadly classified into cell cycle phase specific and cell cycle phase non-specific agents. Cell cycle phase specific agents, in their response, they usually reach a plateau phase, after which even on increasing the dose of the agent, the response or the killing will not increase. Whereas the cell cycle phase non-specific agents, there is a linear dose response curve, where if you keep on increasing the dose, the cell killing will keep on increasing. So we broadly see the classification of the non-cell cycle specific drugs. These include alkylating agents such as cyclophosphamide, carmazine, methylating agents such as procarbazine, and miscellaneous agents such as busulfan, platinum compounds such as cisplatin, carboplatin, and anti-tumor antibiotics such as anthracyclines, and others such as actinomycin D and mitomycin C. Cell cycle specific, those specific to the S phase include antimetabolites such as methotrexate, 5-fluorouracil, 6-mercaptopurine, hydroxyurea. Then we have topoisomerase 1 and 2 inhibitors such as irinotecan and etoposide. And M phase specific drugs include taxanes and vinca alkalies such as vincristine, vinblastine. Now, neoadjuvant chemotherapy. Now, neoadjuvant chemotherapy gives us certain advantages, but it also has certain disadvantages. The advantages include that there is a preoperative regression of tumor. So the tumors that were initially inoperable might become operable, and also that even operable tumors neoadjuvant chemotherapy may allow us to go for a more conservative surgery. Then it helps in treatment of micrometastasis without delay of postoperative recovery. There is less seeding during the surgery. Now, chemotherapy before the blood supply is intact before the surgery, and so the chemotherapy is more reliable. And there is ability to assess the cancer. The cancer's response can be assessed clinically after chemotherapy and pathologically after surgical resection. The disadvantage is that the disease progression while the patient is receiving preoperative chemotherapy. Now, this is very rare, and it is rare especially in chemotherapy sensitive tumors such as breast, but it can be more frequent in resistant tumors such as sarcomas. So, patient selection is very critical whenever we are going to administer neoadjuvant chemotherapy. Also, it poses special challenges such as difficulty in tumor localization, margin analysis, lymphatic mapping, and pathological staging post neoadjuvant chemotherapy. Now, we have to assess the response to chemotherapy, and this response is monitored clinically using imaging studies and physical examinations. Now, this response can be either a complete response, partial response, a stable disease, or a progression. Now, this is done with the help of a RECIST criteria, which is the response evaluation criteria in solid tumors. Now, this is how the various classes are. A complete response is when all the non-nodal target lesions disappeared and all lymph nodes have a short axis of less than 10 mm. Partial response is when the sum of the largest diameters decrease by more than 30% from baseline. Progressive disease is when the sum of the largest diameters increase more than 20% from nadir, and the 20% has an absolute increase of more than 5 mm. A stable disease is where there is no progressive response, or where there is no partial response or progressive disease. And further, then once we have seen the response in this way, then we see the response for the target lesion and the non-target lesions, and then we can provide an overall response. If that, for example, if the target lesion also has a complete response and a non-target lesion also has a complete response, then we have an overall complete response. But if there is some other combination, then accordingly an overall response is decided. Next, we come to radiotherapy. Now, X-rays were being used to treat cancer since within a month of their discovery in 1895. And the possible mode of action of an X-ray is radiation-induced damage to the DNA of dividing cells, or direct and indirect influence on the gene expression. But the goal of radiotherapy is to decrease the local regional recurrence rate. Now, the physical basis of radiation therapy is that the ionizing radiation is energy strong enough to remove an orbital electron from an atom. Now, as we can see here, when by the absorption of the ionizing radiation, the electron is removed from the orbit of the atom. Now, the dose of the radiation absorbed correlates with the energy of the beam, and the basic unit is gray. Radiation therapy that is imparted currently is in the form of either high energy photons or charged particles. High energy photons are usually in the form of gamma rays and X-rays. Gamma rays, they are released from the nucleus of a radioactive atom, and they are usually used in brachytherapy. Whereas X-rays, they are able to transverse the tissue and depositing the max dose beneath the surface, and they spare the skin. Charged particles include electrons, which are used to treat superficial skin lesions, superficial tumors, or surgical beds to a depth of 5 cm. Now we come to the biological basis of radiation therapy. Now, DNA damage in case of radiation therapy is by the loss of cellular reproductive integrity that is manifested by either the single or double-stranded breaks in the DNA molecule, or cross-linking between the DNA strands and chromosomal protein. Now, the mechanism of DNA damage differs by the type of radiation. If it is an electromagnetic radiation, then it is indirectly ionizing. The electron interacts with the water molecule, produces a free radical, or such as hydrogen peroxide, which causes the damage. And protons and other heavy particles, they directly ionize and directly damage the DNA. Now, most cell types do not show signs of radiation damage until they attempt to divide. So, slowly proliferating tumors may persist for months and appear viable. Now, here, as we can see, this is the direct and the indirect effects of ionizing radiation on the DNA. Now, there are certain factors that affect radiotherapy. First is hypoxic cells. Less radiosensitive than the radiotherapy will, in case of the indirect effect, well-oxygenated cell will have better response to radiotherapy, because there will be more chance of generation of free radicals, and the free radicals will also survive for a longer time. So hypoxic cells are less radiosensitive than irradiated cells. Secondly, the phase of cell cycle, that is direct damages from indirectly ionizing radiation, is dependent on the phase of the cell cycle. The G2 and the M phase are most radiosensitive, whereas the G1 and the late S phase are less radiosensitive. Then we come to something known as fractionation and reassortment. Now, delivery of radiation in divided doses is known as fractionation, and this allows the surviving G1 and the S phase cells to progress to the more sensitive phases, which is known as the reassortment. Now, fractionation has certain advantages and disadvantages, which we will look a little ahead. Also, factors affecting include chemical modifying effects of radiation, such as we can have hypoxic cells and sensitizers such as metronidazole, which mimic oxygen. Thymidine analogs, which add to the DNA structure. Thymidine is added, and it makes the DNA more sensitive to radiotherapy, and others such as 5-fluorouracil actinomycin. Now, now we have Withers 5 hours of radiotherapy. Basically, the points that were covered here is what Withers speaks about when he talks about reoxygenation. How he gave the 5 hours of radiotherapy. How hypoxic cells are less sensitive. Repopulation might, in between the repopulation might help us. It leads to rapid tumor growth as a response to radiotherapy. And redistribution is the same, that different cell cycle phases respond different to the radiotherapy. Now, when we talk about adjuvant radiation therapy, it can be preoperative, postoperative, brachytherapy, or intraoperative. Preoperative, the advantages are that it allows for a smaller treatment fields because operative bed has not been contaminated with tumor cells, and inoperable tumors may achieve adequate reduction. Although disadvantages that there is increased risk of postoperative wound healing problems. Post-operative, the advantage is that the therapy can be modified on the basis of the marginal status, and the surgical specimen can be evaluated histologically. Although the disadvantage is that the volume of the normal tissue requiring irradiation may be larger, and adhesions may decrease the mobility of the small bowel loops, increasing the risk of radiation injury. Now, brachytherapy is when the radiation source is in contact with the tissue being irradiated. Now, here the source that we can use includes cesium, gold, and the administration is via temporary or permanent delivery implants such as needles. And the advantage is that the patient convenience owing to a shorter treatment duration has made intracavitary treatment approaches popular for the treatment of breast cancer. The disadvantage is that it leaves scars at the catheter insertion site and requires special facilities for inpatient brachytherapy. Intraoperative, it has a short delivery approach and can be used with combination with external beam therapy. Now we come to very briefly the practical approach of radiotherapy. Radiotherapy is delivered in a homogeneous dose to a well-defined region that includes tumor and or the surrounding tissue at risk for subclinical disease. So we have to define the target. We design the optimal technical setup to provide the uniform irradiation, and we deliver radiation after choosing a schedule of treatment that delivers radiation to the target so as to maximize the therapeutic ratio. Now, this in detail is how clinical radiotherapy works. We first figure out the target and the dose limiting organ with the help of the modalities that are available to us. Then the dose is the radiotherapy dose is optimized depending on the therapeutic ratio, and the technical setup where we put reference status and we use the imaging that is available to us to ensure that the radiotherapy is provided to a very precise area and the surrounding tissue is not damaged. Now, some special modalities that are upcoming modalities with respect to radiotherapy. One is the intensity modulated radiation therapy that uses 3D conformation. That is basically 3D conformation radiotherapy, so that more effective dose is delivered while minimizing exposure to surrounding healthy tissue, and mostly used for brain, breast, and patients who have previously received radiotherapy. Then we have image guided radiation therapy that uses 2D and 3D imaging to ensure that the positioning of the tumor will match to the dose delivery. What happens is that during the process of delivering the radiotherapy, that due to movements of the body such as breathing and bowel and bladder, the target organ may move, and IGRT helps to locate and track this movement and therefore deliver precise radiation. Finally, we have stereotactic ablative radiotherapy, which provides highly focused radiation treatment and intense dose of radiation concentrated to a well-defined tumor. And this is specifically very important for brain metastasis and for tumors of the spine. It is highly effective and accurate, non-invasive, and a convenient outpatient service requiring not more than 30 minutes to 1 hour. Now, the limitations of radiotherapy is that the therapeutic ratio cannot be easily calculated, because although when we give the radiotherapy, we can assess the tumor response immediately, but the long-term damage or the late damage cannot be assessed because that might occur after weeks or years also. So acute reaction is not a reliable guide to adverse consequences of treatment in the long term. So we come to fractionation. Fractionation, if we divide the dose of the radiotherapy for a given total dose, the smaller dose per treatment, that is the larger number of fractions, will lead to less severe side effects, especially the late side effects. But the greater number of fractions of the daily treatment, the longer the overall treatment time, and the greater chance for the tumor to proliferate. And thereby fractionation, although it has its advantages, but all kinds of fractionation is a compromise. Now the side effects, we see that the side effects can be acute or chronic. Acute occur within 2 to 3 weeks of therapy, and chronic occur within weeks and years of the therapy. And they can be plotted on a sigmoid curve. As we can see from this curve, with increasing dose, at a lesser dose, the chance of complications is less, but the tumor control is also less. And as we increase the dose, tumor control increases, but there is a higher risk of complications occurring. Now, as we see that there are multiple complications of radiotherapy, nearly involving all the systems, including something very similar that especially medical students are very used to saying, nausea and diarrhea. and then something serious complications such as cerebral edema. But the thing is, that is why we have to be very careful while imparting radiotherapy, because it has side effects that affect nearly all the systems. Now, finally, a brief word on the principles of combined therapy. It is designed to combat drug resistance. Cancer cells, through spontaneous mutation, develop resistance to cytotoxic drugs, and this might lead to expansion of clone cells. And this is unlike antibiotics because no previous exposure is required. A cancer cell might spontaneously mutate, and there is a chance that it might be resistant to any cytotoxic treatment. Now, the choice of drug combination depends on use of drugs active against disease in question, the use of drugs with distinct mode of action, use of drugs with non-overlapping toxicity, and consideration for spatial cooperation. Advantages of neoadjuvant chemoradiation include that it is now the standard of care. Chemotherapy increases the radiosensitivity to radiation. It has superior R0 resection and higher complete pathological response. Thank you.
Excellent presentation, Milind. Just one question, if Professor Shah allows me. Why is it that the chemotherapy is given in pulses?
Sir, chemotherapy is given in pulses, sir, because sir, there is one of the principles of Vedas, sir, the time to heal, sir. So there are 2-3 things to. One is it helps us differentiate between normal and the cancer cells, because what it does is that cancer cells and normal cells heal at different rates, so it allows slight healing of the normal cells. Secondly, sir, once the number of cancer cell decreases, the amount of oxygen that is being used by the other cells increases, so the remaining tumor cells become more sensitive because of higher oxygen availability to the tumor.
Sure. Because you said there are 2 types of chemotherapeutic agents, cell cycle specific and non-cell cycle specific, isn't it?
Yes, sir.
They call it non-cell cycle specific, but actually if you consider that chart, you have chemotherapeutic agents which target the S phase, isn't it?
Yes.
So, I mean, they call it non-cell cycle, but it is actually, as you said quite rightly, it works on the principle of which phase it, S phase specific. You have to encourage the cancer cells to reach that S phase again, isn't it? So you have to allow the cancer cell, which has, some cells which have survived your first, to repopulate that S phase again. So in a way, though we do call it a non-cell cycle specific, and it is actually, as you said, cell cycle specific. It targets the S phase and the M phase.
Yes, sir.
Okay. The other thing is, what are the radiomimetics?
Sir, pardon?
Radiomimetics.
Radiomimetics. Radiomimetics are essentially drugs which mimic radiation effect, but they've fallen to disrepute because of they actually, if you're using it as a parenteral treatment, it causes a huge amount of lung fibrosis, isn't it right, Professor Shah? We have had to, busulfan is a medicine that people are very careful of using, because if you have any modicum of chest problems, you end up creating a respiratory cripple. Okay, so these are the radiomimetics, the drugs which mimic radiation. The other thing is, you're absolutely right. It works on the basis, it targets, radiation targets the cell cycle directly, or by production of free oxygen radicals. OH is fine, yes, but also free oxygen radicals. The other final question I wanted to ask, where would you classify in your treatment of transarterial radioembolization, where we use yttrium? Where would you classify this medicine, this drug?
Sir, it would be. So I didn't get the question, sir.
Transarterial chemoembolization.
So that would be breaking therapy.
Yes, very good, excellent. I wanted you to think it out. Very good. It is a sort of brachytherapy, isn't it? Professor Shah, I'm open to any other questions if you want to ask any other questions.
And another thing is, cancer development, there is a concept called cancer stem cell. So the limitation of chemotherapy is as you said, it kills a group of cells. And in this, the cancer stem cells are spared. So they are the reason that even after chemotherapy, cancer may relapse. So these are cancer stem cells, which are not always killed by the chemotherapy agents. Dr. Maiti, any comment?
Actually, today the subject is very vast, difficult, as well as very essential. I can say that students have taken the subject very sincerely. They have worked hard and prepared the slides. But as Dr. Devokshi has already mentioned, they should take care little more in keeping the standard of the slides, particularly the selecting the fonts and the lines. And regarding discussion, wonderful discussion, and the comments and the questions, really very important. And I think more discussion may be needed in a very concise form. But today, I think the subject was so elaborate for the beginners. It may be very difficult to grasp everything. So you can make it in a very concise form, in the form of axiom, in the form of dictum, so that will be more impressive and penetrating to the student. And one comment I can make, that diagnosis of a cancer through the biochemical markers and the cancer oncogen markers are very important, but the other investigations like the imaging investigations should take more importance in the diagnosis than the markers, because very often we have been misguided and misled to make a diagnosis, a wrong diagnosis on the basis of these markers. I can remember one case in Medical College, Kolkata. The CA 19-9 was more than 1,000, but the patient had Whipple's operation, and the ultimate histopathology came as chronic pancreatitis. That may happen, but the treatment was okay because the patient was having the problem for a long time, but the diagnosis may be mistaken by these very high markers. It has already been discussed by you. Thank you for the very good discussion in this subject. Thank you. Thank you, Dr. Moxie and Dr. Saha.
Yeah, actually the markers, as you said, the markers are not for diagnostic purposes. Markers are more for prognostication and for follow-up. And more so with the advent of the newer therapies. Newer therapies are more target-oriented therapies. So we have to have a good diagnosis and analysis of the tumor tissue in the form of finding the gene mutation, so that these are the more specific tests which will dictate whether these targeted therapies are effective or not. Because targeted therapies are applied only when we have this marker being positive. We have demonstrated a definite gene mutation. So here the importance of this markers and other genetic studies, which can help in the planning of therapy also. Okay, Dr. Devokshi, any last comment?
No, I think the students did a wonderful job. It's a huge topic, and I think I commend all the three for touching on the vital aspects. Don't you agree, Professor Maiti and Professor Shah? They've actually touched on all the vital aspects. It's a huge topic to cover within 1 hour, but I think they've done a wonderful job. Great job, guys.
Thank you. Thank you, Dr. Devokshi. Thank you so much.
Okay.